Over to you, Dr. Masjid.
Hello,
Kapil sir, if you
good
can reply
afternoon.
the questions in the chat box, it will be helpful for us. Thank you, sir.
I will do it. Thank you.
Hello, yeah, good afternoon. Am I audible?
Yeah, you are audible and screen is visible. Please go ahead.
Yeah, okay. So, many points of my talk has already been covered by Dr. Samarth and Dr. Kapil. So, let's go through the talk and just revise the topic. So, what defines then unstable IT fracture? So, unstable according to AO classification, all three, one, A2.2 and A2.3 and all A3 are unstable. Like in A2, A1 fractures and A2.1 fracture if is a stable one, and A2.3 and A3 are all unstable. And we'll see in detail further that AO has classified the A2.1 as a stable because it has a lateral wall more than 20.5 millimeter. So apart from AO classification, these are the features or these are the fractures which you classify as unstable: posterior combination, lateral wall combination or blowout, lateral cortex or GT coronal split, reverse obliquity, and subtrop extension. So why the calcar matters? Because it is a loss of calcar and plus minus LT fragment that leads to loss of support of the posterior medial fragment. And if it is lost, there can be causes of failure. Like in varus collapse, broken calcar leads to medial compression and will further leads to progressive varus deformity. And it can also lead to screw cutout. The stress shift from calcar to the cancellous bone around the lag is true, so there will be chances of screw cutout. And implant will be overloaded and fatigue, so it can lead to breakage, nail failure, or periprosthetic fractures. And so in posteromedial combination, we have to rebuild the medial cortical continuity and improve the stability. And the studies have shown the loss of posteromedial cortex will lead to decrease the maximum load tolerance and increase the stress as the infromedial nail through junction. So fixation of LT or medial buttress reduces the varus and the cutout. So after having focus on the posteromedial combination, the current understanding or the recent advances, we focus more on the lateral wall integrity and the anteromedial continuity. Because even if in posteromedial combination, if the lateral wall is fine, or we deal with the lateral wall in a stable manner, or anteromedial continuity is there, then the posteromedial combination don't matter. So the role of lateral wall, it acts as a buttress. It controls the collapse and mineralization. And if it is lost, then there will be uncontrolled sliding and varus deformity. So we are talking on this again and again, that lateral wall thickness less than 20.5 millimeter, which is measured usually uh, 3 centimeter below the innominate tubercle and in the angle of 135 degree. So if it is less than 20.5 millimeter, then it is unstable and it significantly increases the risk of secondary lateral wall fractures. And it predicts the failure with the DHS like implants or any other implants, extramedullary implants. So this is that study which have changed the A classification. And here we can see that here the lateral wall is more than 20.5 and here it is less than 20.5 millimeter. So the DHS or DHS like implants is not for this type of fractures. So what are the options for this lateral wall blowout or lateral wall combination? So there are intramedullary fixation implants which have advantages of more favorable mechanical properties. These are closer to the center of gravity, have a shorter lever arm, and so the bending forces on the bone and the implant is less. So the real advantages which are not advertised are mainly intramedullary implants have a intramedullary buttress that resists the excessive fracture collapse. It also resists the relatively higher forces across the calcar and substitutes for posteromedial and lateral cortex stability. So what we'll do for lateral wall fixation? So lateral wall, if it is lost, it is associated with significantly higher reoperation rate with DHS. So we have to use intramedullary implant or PFN. So PFNA alone is adequate, as shown in this study, if these are following are the prerequisites. Anterior cortex should be aligned, medial cortex should be neutral or positive, valgus reduction is mandatory on valgus or neutral reduction, and blade should be center to center, TAD usually 20-25 or less than 25 in osteoporosis patients. So what are the radiological clues which will see and predict that the lateral wall is deficient or lateral wall is comminuted or broken? So first thing is after giving the traction and reducing, and after giving the traction and internal rotation, if we see the lateral wall is either broken or thin, then it is uh, obviously unstable IT. And if the GT fragment is very large, if the entry point we are going through the fracture side only, and the excessive ribbing during ribbing it gives away, then these are the clues that the lateral wall is deficient or there is a blowout. So after lateral wall, the other unstable variety is a coronal split intertrochanter fractures. And the split is usually on the posterior aspect of the greater trochanter. These are very common, but usually are underdiagnosed, and it is usually best seen on CT cuts. So the coronal GT fragment behaves as an independent unstable fragment, and it compromises the lateral wall integrity and abductor continuity. So after seeing the X-ray, if we are predicting that the coronal split is there, we should plan for CT also. Uh, in the cases of coronal split fractures, there is a poor control of the GT fragment, and that will lead to failure to control the fragment, leads to loss of lateral buttress or abductor dysfunction. So here also the choice of implant is intramedullary, because there is a high risk of nail loosening, loss of reduction, varus collapse, or delayed functional recovery if it is left in situ. So we should intermediate implant is the choice of implant, and the plan for augmentation or supplementary fixation will be can be needed if if the fracture is not so much stable. So why do these unstable ITs like postomiddle combination, lateral wall blowout, or coronal splits fail? Because they fail in the following: either in varus collapse, or excessive sliding, or implant cutout, or middleization of the shaft. So what are the preoperative planning or the tips to improve the outcome in these type of cases? So the threshold for CT scans should be less. So if we are able to see on X-ray only, then it will not be needed. But CT scan is usually needed to look for the either coronal split or any other unstable variety of the IT fractures. And we should identify the GT combination, coronal split, and lateral wall thickness. And we have to decide if we are augmentation is needed before the surgery only. So the reduction principle are like already have been mentioned by Dr. Samarth and Dr. Kapil. Anatomical or near anatomical reduction is mandatory, and we should correct valgus, varus, posterior sag, and rotational malalignment. We have to remember that poor reduction, even augmentation will fail in these type of unstable varieties. And the reduction tricks have already been mentioned, like we have to use these type of tools or in a traction table with internal rotation. We can use shank pin, we can use bone hook clamp for GT, or we can use temporary K-wire fixation before doing the nailing. The entry point already has been described very well by Dr. Samarth. We should avoid lateral wall blowout. The reaming should be very gentle, and we should be beware of false lateral or false easy passage. And the lag screw or the blade placement usually is central is preferred, or inferior, just inferior to the center, or tip apex less than 20 to 25, or fracture gap should avoid the fracture gap penetration. Now coming to the augmentation, when is the augmentation needed in these unstable varieties of IT fractures? It can be needed in either broken or thin lateral wall or coronal split GT fragments, persistent instability after nail insertion, and in cases of very poor bone quality. In very poor bone quality, we may augment with cement also. What are the options for augmentation? These are various options, and are usually commonly used: circulage wire, or anterior posterior screws for holding the sagittal split GT fragments. Polar screws or additional screws can also be used, or trochanteric stabilization plate. If we are using DHS, then trochanteric stabilization plate is usually needed for these unstable varieties of IT. So what are the tips for using circulage wire? These are usually indicated for spiral, oblique, or any other GT comminuted fractures. First of all, we have to open the fracture to use these, or either open or mini open technique is used, or percutaneous technique is used to to apply the circlage wire, and it will also add the time, but we usually avoid strangling the soft tissues very much. And AP lag screws or PFN with the trochanteric stabilization plate, we should restore the lateral buttress and abductor continuity. So these are some of the examples of using the AP screws in cases of coronal split GT fractures. These are the examples of using the trochanteric stabilization plate along with the PFN. So this is one of the case uh, described by by Yu Shi Gao in a paper. So they have used a circlage wire technique in these unstable type of fractures. So they first applied the clamp and then applied the circlage wire. So we should just remember that we have to apply the circlage wire, or we should before doing the nailing or before inserting the guide wire. Yeah. So, and this is one of our cases in which there was a coronal split and the fracture is extending way below the GT subtroch level also. So in this case also we have applied the coronal this AP screws and also the circlage wires. So coming to the trochanteric stabilization plate, because trochanteric stabilization plates can act as a lateral wall substitute and it prevents the excessive collapse. So if we are doing DHS, which is the extramodular device, we can add on trochanteric stabilization plate, especially in osteoporotic bone, to prevent these complications of collapse and uh, medialization of the shaft. So this is one of the example of applying the additional augmentation plate in the IT fractures. So the common pitfalls is ignoring the GT combination, relying only on the tip apex distance and poor reduction with the good implant and late decision to augment. So the take home message from my talk will be the lateral wall integrity is the key determinant of stability. We should always prefer intermedullary fixation implants for all the unstable ITs. Augmentation is usually proactive, not salvage, and avoid unnecessary augmentation because it disturbs the biology. And the main point is good reduction is always better than good implant. Thank you.
Thank you, Dr. Masjid. And actually, it's one of the difficult fractures where you find a coronal split. But many times, while saving the fragment, you go further blowing out the trochanter, and at the end, you find that I'm really stuck. What to do next, and then leave it to the God. So, but many times it also gives a chance to reconstruct the best possible way. Even the lateral trochanter plate you find, but you don't find space to put the screws.